Okay, so we left off with the nasal cannula and the non-rebreather. So we'll just talk about a couple other devices, and then we'll start up with the vital signs presentation. Did anybody have any questions on anything we were speaking about as far as the airway equipment last week? Okay. Okay, so this device we're never going to be using ourselves. This is called a Venturi mask. This is a mask that typically people who have breathing problems, mainly emphysema, the overall disease is something called COPD, chronic obstructive pulmonary disease. There's two types of chronic obstructive pulmonary disease we're going to cover when we do respiratory emergencies. There's emphysema, which is a disease that damages the alveoli, the air sacs. The main cause nowadays of emphysema is cigarette smoking. It could be exposure to occupational dusts and gases and stuff, but now with the strict OSHA regulations, most people are wearing masks when they do that type of work, so that as long as they're wearing the proper mask, they're protected. So the main cause of emphysema nowadays is smoking. And then the other condition is called chronic bronchitis. So any one of us may have had bronchitis, which is just an infection in your bronchioles where you cough a lot, have a lot of mucus and stuff, at some point during the year. People who have chronic bronchitis have it all year round. In fact, the definition of chronic bronchitis is they have a productive cough. In other words, they bring up mucus when they cough more than 3 to 6 months out of the year. So they've damaged their cells that make the mucus in their body. So remember, mucus is supposed to be in our body. It's a protective substance that helps us keep things out of our airway that are not supposed to be there. But if you damage those, they overproduce the mucus, and people basically have so much mucus production they can't breathe. So in both of those conditions, what happens is that normally we said the body registers the amount of carbon dioxide to tell us to breathe, and if the carbon dioxide is too high, we breathe more. If the carbon dioxide is too little, we breathe less. But in this condition, because these conditions take years, decades, tens of years to develop, the body gets used to having the higher levels of carbon dioxide in the body. So it tricks the body and says, it's not a problem if the carbon dioxide levels are low. But the body adapts to that and says, okay, instead of looking at the levels of carbon dioxide, I'm going to start looking at the levels of oxygen, right? So now they have a second system. So we look at carbon dioxide. People who have long-standing respiratory problems, they look at the level of oxygen. So now if we were to come along on one of these patients who's having shortness of breath, we would say, okay, let's give them some oxygen. They're having shortness of breath. But the problem is, since they look at the level of oxygen to breathe, and they breathe when their oxygen is low, they call it hypoxic drive. Remember, hypoxia is low oxygen. So they call it the hypoxic drive, right? So they look at a low level of oxygen. So if we're giving them oxygen, their body's going to say, well, we have plenty of oxygen in our bodies, so let's slow down the breathing. And we don't want to slow down the breathing and make the breathing shallow and somebody's having shortness of breath. So what these devices do is they deliver a specific amount of oxygen to a patient. And we can't do that with the non-rebreather, right? We're kind of always up in the 90% range and stuff like that. But with these devices, we can deliver a very specific amount. Now, we don't use these. These are devices that you're going to find on patients who are on home oxygen. So if somebody has to be on oxygen in their home all the time, you know that they are having severe breathing problems. And there's many different reasons. It doesn't have to be this chronic obstructive pulmonary disease, this emphysema and chronic bronchitis. There's other things that could cause it. But if they do have that history and they're on this, what will basically happen is they'll have what's called a machine in the house called an oxygen accumulator. And what it basically does is it takes the oxygen out of the air and concentrates it, okay? And it delivers it at a higher percentage. Because remember, in the room, it's only 21%. So it basically brings it into the machine. It removes all the other not waste products, but all the other gases that are in the air and concentrates the oxygen and then puts it back out to the patient. So it's a way of having, an oxygen source in your house without having to constantly replace oxygen tanks. But it doesn't get upwards of as high as the pure oxygen that we're administering patients. Typically, it gets as high as about 30, 40%. But anyway, what this device does is based on the doctor's prescription, it administers a specific percentage of oxygen. So again, the percentage of oxygen we're breathing is 21%. They may say this patient needs 24% or 28%, and it administers a specific amount. Now, the family should know, how many liters per minute you should set the oxygen to. So when we adjust oxygen from a regulator, we adjust it like a dosage basically on how many liters of oxygen come out per minute. So this device has different fittings that are designed to run with different liters per minute. So you just have to ask them, how should we, continue that patient? Now, obviously, if you can't figure it out, or, the patient's, it's too, taking too long or something like that, then just put them on a nasal cannula and start transporting them, and they'll figure it out in the hospital. It's not something worth wasting time over. Okay, so again, a Venturi mask. A Venturi effect has to do with airflow. When air flows through something, it draws with it. So what happens with this is that the oxygen mixes with the room air and delivers a specific amount of oxygen. That's all it really does. So it's basically the pure oxygen is being diluted with the room air, and that's the Venturi effect. That's why they call it a Venturi mask. Now, a tracheostomy mask, a patient who has a tracheostomy means they have a surgical opening in their throat. Now, the other day we saw somebody who had a stoma, which is, I could say similar, but not really similar. What happens is that sometimes people have breathing problems, okay? And they need to be intubated, right? They need their breathing tube in. But if they're going to continue having those breathing problems more than, say, a week or two, they don't want to leave the tube in them because, one, they can't talk while the tube's in them. So quality of life-wise, it's difficult. Two, there's a higher risk of infection, okay, by having a tube in your lungs. So what they do is they make a surgical opening into the trachea, okay? And, that's what basically happens. When we were looking at the stoma the other day, that's somebody who actually had part of their larynx, part of their trachea taken out because they had cancer. And that's, that person's not, once they remove the cancer, that patient never had any breathing problems. They don't need to have a machine breathe for them. They're not going to need oxygen or anything like that. But a person has a tracheostomy, they're having breathing problems. They're typically going to have a machine, a ventilator breathe for them. So they basically have a permanent opening in their neck that there's a tube inserted in that you could hook up the bag valve mask to, you could hook up a ventilator to. Now, what this is saying that some patients, they have good effort to breathe. In other words, their lungs are moving, they can bring air in, and these patients may just need a little extra oxygen, right? So they may need a little more than room air. So they have a device, basically a little mask that fits over the patient. There's a port, you can't really see it well, but there's a port that the oxygen plugs into. And so now when they're breathing in, they get a little more oxygen. This is not what actually goes into the patient. None of this is what goes into the patient. This is sitting on the outside of the patient's hole in their neck, and the strap goes around their neck. This is just kind of like an exhaust port. That's all that is. I can't see on the picture very well where the oxygen would actually plug into it. So again, it's rare people are home that have tracheostomies are home. They're usually in nursing homes and stuff like that. But if you saw it, that's what it basically is. And again, if you ever see this equipment and you're not familiar, you don't remember, you don't know what it is, there's family members that are well versed, understand it, or they have a caregiver, they have a nurse, or they have an aide or somebody there that we could explain to you what the situation is. Okay.
I see it's got the two holes like the non-rebreather. Do they breathe the same way as if you would put it on their mouths?
Oh, I didn't even see those. No, so no, they're only breathing through that opening in their neck. I mean, well, actually, I shouldn't say that. It depends on the type of tracheostomy they had. So they could breathe through their mouth and nose probably, but because this hole in their neck is closer to the lungs, they tend to breathe through here, right? So like, in other words, why would you breathe through your mouth and your nose if you could just breathe through here? So that's, again, just a way of bringing in some outside air, I guess, or diluting the oxygen that's coming in. I didn't even see it until you pointed it out. So I don't know if they all have it because I never saw that before on a tracheostomy mask. And it's very rare. I mean, I've seen maybe this 5 times, 6 times, in 30-something years of doing this. It's not that common. Now, if you do a lot of interfacility transports, non-emergency, you're going from a nursing home to a hospital with a patient, stuff like that, you probably see more of this because there's more people, who have tracheostomies in nursing homes. Okay, so let's talk about some special considerations. So what could give us problems with people's airway? So anytime there's any bleeding, okay, any trauma to the mouth, nose, airway, or anything like that, that's obviously going to be a problem. Now, we do have suction that we could, use to remove it, but the problem is that while we're providing suction, it'd be very difficult at the same time to take care of their airway. So it definitely could be a problem. Swelling can occur from an allergic reaction, right? So we do have epinephrine to administer in those situations. We'll talk about that when we get to anaphylaxis or a severe allergic reaction. But it could be swelling from, say, chemicals or burns or something like that. We don't have anything to deal with that on an EMT level. Even on an ALS level, we don't have that much too. But those are those are patients that you would not be able to manage their airway in the field. So it's fast transport to the hospital, doing what you could do, for those patients en route. So, there are certain airway emergencies that really cannot be dealt with well in the field. And to be honest with you, there's some airway emergencies that can't be dealt with at all, that patients die. Okay. So, that's the situation with fluids and swelling and stuff like that. I mean, there's really nothing. I mean, sometimes with severe swelling, not that you would do it on a BLS level, let's say you have severe swelling in the upper airway, in their mouth, their nose, something like that, you may actually have to make a surgical opening into their trachea to be able to breathe for them, because above it is all blocked off. Okay, so we know that choking, whether it be from foreign bodies or whatever, in other words, a foreign body with like food or a toy or something like that, can obviously, if somebody has a complete airway obstruction, or even a severe partial airway obstruction, can interfere with their ability to breathe. So we talked about that any patient over 1 year of age, we could do the Heimlich maneuver, or they call it the standing abdominal thrusts. Okay. And we continue doing that until either the object comes out or the person becomes unresponsive. If the person becomes unresponsive, okay, we lay them down and start CPR on them. Remember, the CPR we're doing is not to circulate blood in this situation. It's to compress their sternum on their lungs to blow the obstruction out. And if they're under 1 year of age, we do a combination of back blows and chest thrusts, 5 back blows, 5 chest thrusts. And if they, again, become unconscious while we're doing that, we start CPR on them. So the other thing says, if unable to ventilate, consider possibility of obstruction. So if you're ever trying to ventilate somebody with a bag valve mask, you may not know the whole story of why they're not breathing. If you're not getting air in, one of the things to consider is they could possibly have an airway obstruction, right? I mean, there's, again, without an X-ray, without CAT scan, there's no way 100% to know, but it's one of the things that could happen. On the test, if they ask you were attempting to ventilate with a bag valve mask and you were meeting resistance, what should you do? They're going to expect you to answer that you would reopen the airway. In other words, if you were doing the head tilt chin lift, you'd repeat it one more time just to make sure that the problem is not the tongue, okay? And that to make sure you're using your oropharyngeal airway or nasopharyngeal airway. Okay,
so if you go to back valve mask and you see that there is obstructions and you're suspecting that the airway is blocked, what is your next step? Like you start CPR because he's unconscious now?
so if you think there's an airway obstruction and they're flat on their back, then yes, you would have to do CPR, because you can't like hold them up to do the Heimlich maneuver on them. So yeah, you would have to start CPR. So a lot of this stuff is theoretical. Like in real life, I mean, could it happen? Yes. Does it happen? Not really. I mean, all these situations could arise. Have they happened? I'm sure. But do they routinely happen? No. I mean, it just, it doesn't, it's not things that you routinely see, all these little weird situations and stuff. But, obviously things happen. There's always possibilities of things happening. Now, when they talk about dental appliances, they're talking about dentures and fake teeth and stuff like that. So like I said the other night, dentures are not as common as they were years ago, okay? Better dental health care, better, mouth hygiene, people brush their teeth more and stuff like that. And there's also what they call implants. So, people have enough money, they can actually, drill fake teeth into their gums in place of dentures and stuff. But what they're saying here is that if you have a patient who has dentures in place, leave them in place. If you have people have dentures out and they can put them back in, have them put them back in, because it's easier to work on a patient with their teeth in place than it is without. And it's kind of hard to picture, but somebody without their teeth in place, their mouth looks like you could put your whole arm in it. It's just such a huge opening without the teeth in place that when we go to use the bag valve mask, the mask actually doesn't fit on their face. And I know you can't really picture it because you've never seen it, but it's scary. Like if you saw them open their mouth and smile, it would look like they're trying to swallow your head. That's how big the opening is. So it just makes it difficult to use the bag valve mask because the mask doesn't have any place to seat itself on other than the nose, right on top of the nose. So as much as possible, we leave it in. But remember what I said also, don't ever transport dentures to the hospital for the patient. Let the family do it, because if they get lost, they're thousands of dollars. And you don't want to be the person who was last taking responsibility of them. Now, from a pediatric, from a child standpoint, right? So the metabolism of a kid, right? The burning of energy, the needs, the perfusion needs, the food needs of a child are much higher than that of adults, right? Because their body's growing, everything's going faster. You see that because their heart rate is faster than an adult and everything like that. So everything's much faster. Okay, because of that, they need more of the fuel. So they need more oxygen. So when they're having trouble breathing and they're not getting that oxygen, they get sicker quicker. Now, the good part of a kid is that for the most part, okay, kids don't get sick. And when they do get sick, they have an otherwise healthy body. So they're usually, they deal with it well. So we more worry about the kids that are born with medical problems, and those are the ones that tend to, deteriorate or get worse very quickly. But you should always think about that, a child who's having trouble breathing because they need more oxygen, so it made the numbers may not look terrible, and maybe their pulse ox is 94%, 93%, 92%, where we'd be concerned, but we'd not be crazy in an adult. It may be more serious, in a child. But if the kid has chronic medical problems, one of the things you want to say very quickly to the parents or to the caregiver is, what is their normal pulse ox, right? I mean, if they're sickly kids, they probably have pulse ox in the house. What's their normal pulse ox? If they say they always run at 92%, you're not going to be as concerned as if they say to you, no, their pulse ox is usually above 96%, which we really consider above 94% normal. If they were saying, no, they've always run a little low, then you wouldn't be as concerned, okay? Especially if they're awake and talking to you. When they say mentating, that means they're thinking, okay, as you would if they were having some type of problems. Okay, so we talked about the other day, we saw pictures of some of the anatomical differences, right? The tongue, I talked about in proportion to the size of the mouth, takes up a lot of space, okay? Again, this is in comparing to an adult. Like an adult tongue in a bigger mouth doesn't take up as much space as a kid's tongue in a smaller mouth. That the tongue is a muscle, and the muscles, all the kids' muscles are weaker than an adult's muscles, so their tongue can relax easier, right? There's just a whole bunch of anatomical situations that make it a little more difficult for a child who's having trouble breathing to deal with it. That's all they're really saying there. Okay, and then, the other big problem is that since they need that more oxygen, when they can't get it in, they show those signs and symptoms quicker. And like I said, fortunately, we don't see a lot of sick kids. Okay, so ventilating the pediatric patient. So using the bag valve mask, the child is either not breathing or breathing poorly, okay, and we need to assist their ventilations. Remember, it'd be pretty rare where you would be assisting the ventilations of somebody whose eyes are open and interacting with you, right? This is typically unconscious patients. So we want to avoid, right, delivering too much pressure and too much volume. What's the difference between pressure and the difference in volume? Volume is the amount of air that's inside the bag valve mask, right? So we never typically have to ventilate and squeeze the entire bag valve mask into a patient, no matter what the size is of the patient, because, obviously we're using the smaller size bag valve masks on the smaller patients. So the reason we don't want to overventilate, right, is that we could damage the lungs. If the lungs are already fully filled and we keep on pressing, we're going to get some air down into the stomach, because the throat connects both the trachea and the esophagus, right, come up into the throat. And if we get air into the stomach, it's going to press on the diaphragm. It's going to make it harder to ventilate. So we're going to even be pressing harder and make it worse, or they could vomit if there was food down there, right? So we just want to watch the pressures that we're delivering and the volumes we're delivering, okay? Once we see the chest start to rise, we stop ventilating, okay? Now, each bag valve mask comes with one mask in it, one size mask. That doesn't necessarily mean it's the right mask for every patient that would fit into that using that bag valve mask on. So, the problem historically is that the person who buys the supplies doesn't think about all those types of things when they're buying supplies. But what you really should have is, like I said, you should have a newborn bag valve mask, an infant bag valve mask, a child, and an adult. Some people even go small child and large child. So you're talking minimum of 4, if not 5 bag valve masks. The average ambulance only carries 3. Okay, and then you probably need to have about a dozen different size masks, both adult and pediatric, so you could fit every shape of every patient, right? And again, most ambulances, since they have 3 bag valve masks, have 3 size masks. So sometimes it becomes a challenge. Now, again, most people's faces are not that different. So again, we get away with it, but sometimes it can be, can be difficult. Okay, now we showed that device that I told you that when you press the button, the oxygen comes out at great force, right? That's that flow restricted device where there was that button and they were pressing it in, the air would just flow into the patient until you stop pressing the button. So we don't use it in adults anymore. We never used it on kids, okay? Because you could just deliver very quickly, deliver too much volume and hurt the patient. So those were never, designed for pediatric patients.
What button are we talking? Is that the part?
That was, let's see, I think it was in this slide. Let's see if we can. All right, this was it. So it's a little hard to see, but they're basically making a two-handed seal on this mask. Now, if you look up, you see his fingers right on this little lever. So right on the top here, there's a button. When they first came out, you actually had to press the button. Then as time came on, somebody invented this little lever that when you pulled on it, you could actually ventilate it. So it made it easier because then you could use two hands to make a seal on the mask. But when you pull on this, this is connected. See this heavy green hose? This is connected directly into the high side of the regulator before it gets down pressured. So when you're pressing that, it's pretty much, I don't want to say the full pressure of the oxygen tank, but it's more pressure than, it would be like if somebody was blowing a leaf blower in your face and you were trying to breathe. It's high pressure, right? So as long as you continue to press that button, air continues to flow. So it's all on the person who's operating this to pay attention to what they're doing. And the problem was that, you know, again, inexperienced people not using it the right way, you know, hurting the patient and stuff. So we really kind of gotten away from, you know, gotten away from using it.
Something like that would probably blow his tongue and like clog his airway.
No, it didn't really do much to the tongue. The problem was the damage to the lungs. And again, since, you know, when you guys are ventilating, you don't have a tube going into their trachea, you're ventilating their mouth, which is then going into their throat. And then the problem again is the throat splits to, right, the trachea and the esophagus. So when you pressurize the air going into the throat, you're going to get some air in the stomach. So once you get air in the stomach, there's always the risk of vomiting. So it was, you know, it wasn't a great device. I mean, some people loved it, you know, it wasn't, but you had to really know how to use it. And, you know, if you ask the average EMT out there how many times they've used a bag valve mask, it's not so common. You know, I mean, we don't have that many sick patients that we, you know, ventilate with a bag valve mask. Okay. Okay, so we don't use the flow restricted oxygen powered ventilation devices. Okay, you should have pediatric sized non-rebreathers and pediatric sized nasal cannulas, right? Just like, you know, everything else. You have the right size for the right patient. And then we said that if we overventilate, the term gastric means stomach, distension means it's getting bigger. So if you've seen your kids cry and their stomach blows up, right? Because when they're crying, they're sucking air in with such force that it's not only going into their lungs, it's going into their esophagus. So their stomach is starting to get big. So the same thing, if we overventilate someone, we can get air into their stomach. When you get air into their stomach, it presses up on the diaphragm, so it becomes harder for them to breathe. Or if we're ventilating them, it becomes harder for us to ventilate. And the other risk, obviously, is you put air in the stomach and they have any food, liquids, anything in their stomach, there's a higher risk of vomiting. So, you know, we just have to watch how much force when we're ventilating patients. Okay, let's do a quick review. I took out the slides on advanced airway stuff. You know, if we have time towards the end of the class, that's like kind of helping the paramedics with stuff. So it's not anything that you know, have to know as an EMT. It's something, if you go to work in an agency that has paramedics, you'll pick up. But if we have time, we'll practice it. Okay, what's the difference between, I said there's 3 levels of trouble breathing. There's respiratory distress, this is the lowest level. There's respiratory failure, and then there's respiratory arrest. So respiratory distress is the person who just starts having trouble breathing, right? And they're having problems breathing. Respiratory arrest means they've stopped breathing. That's, we call that apnea or apneic, right? They've stopped breathing. And then in between is respiratory failure. So does anybody have any idea, like, what happens for us to say the patients move from respiratory distress to respiratory failure? And obviously failure sounds worse. What do you think?
He's not breathing, he's done.
Nope, that's respiratory arrest, right? So a patient in respiratory arrest is apneic, has stopped breathing. A patient in respiratory failure, what it means is that they were having trouble breathing. Okay, now what did I say? To breathe, you need 2 muscles to work, your diaphragm and your intercostals, right? And remember, small patients, small kids, really primarily just use their diaphragm. So if you're having trouble breathing, what's the level of oxygen coming in? We assume probably less than we need, right? And how much carbon dioxide are we getting out? We assume less than we need to get out, right? So that's the first problem. So now the muscles need fuel, right? Like any muscle in your body, they need oxygen to come in. And if they're getting oxygen in, they're going to need carbon dioxide to get removed. If they're breathing poorly and they can't get enough oxygen, they can't get enough carbon dioxide, what happens to the muscle? It doesn't get the fuel it needs. So remember, metabolism is the burning of the oxygen and the sugar to make energy. So the cells in the diaphragm and the cells in the intercostals now don't make good energy, right? They don't have aerobic metabolism, they have anaerobic metabolism. And we said the problem with anaerobic metabolism, the muscle starts to fail because the lactic acid builds up. Just like when you were using your arms too much and they got tired and weak and shaky, it's the same thing in any muscle. Okay, so now what happens is it looks like the person's still breathing, but since the muscle's not working with the same strength, they start to breathe shallow. And a shallow means that tidal volume, the amount of air we bring in and out, which one each breath, right, is approximately, say, 500 mLs, 400 to 500 mLs. So if we start to breathe shallow, we don't bring that full 500 mLs in there. So we're getting less air down to the alveoli. So it starts this vicious cycle where, you know, the cause of this was they weren't breathing well. And now that they're breathing, their muscles are weak, they're breathing shallow, you know, it gets worse and worse and worse. And eventually they stop breathing. Okay. So what, you know, what happens is when they're in respiratory distress, we try to make them better with medicine. Typically the medicine we give them is albuterol, right? They're having an asthma attack, we give them albuterol. If it doesn't work and they start falling asleep, like what has to happen when somebody goes into respiratory failure is not only the muscles in their chest aren't working, but their brain is not working as well because it's also not getting oxygen. Nothing's getting oxygen if they're not breathing well. So their mental status starts to decline. So that's kind of the hint, because remember I said that somebody who's having trouble breathing is always going to want to sit up and try to struggle to breathe. They're never going to want to lie down. So if you see them starting to like fall over, they can't keep their head up and they're barely breathing, that means they're moving towards respiratory failure. So to prevent them from going into respiratory failure, we use those devices like CPAP and BiPAP that we were talking about before, you know, the other night, that kind of help them when they're awake to breathe deeper. But if it's too late, then we have the bag valve mask, right? So if they're unconscious, we use the bag valve mask, okay, to keep them ventilated because they can't ventilate on their own. So that's what it says over here. It says a patient in respiratory failure or respiratory arrest. So respiratory failure was the patient in respiratory distress that got worse. And respiratory arrest means they've stopped breathing. They need to be ventilated, right? They're not breathing well on their own anymore. If you just put a non-rebreather or a nasal cannula, they're going to die because they're not sucking that air in. You need to push that air into them. That's always the question that we have. Can we give them oxygen that they passively breathe in on their own, like with a nasal cannula or a non-rebreather, or do we need to drive it into them with the bag valve mask? Okay. So this one down here is saying oxygen can be delivered to non-breathing patients as a supplement to artificial ventilation. So what that means is if you're using the pocket mask, you can plug oxygen into it. If you're using the bag valve mask, you could plug oxygen into it, right? If you didn't have oxygen, you could still use both devices without oxygen because we're normally breathe 21%. But you know, if they're having severe breathing, it probably would help them to give them extra oxygen from the oxygen tank. Okay, so that's what they were talking about over there. Okay. So here we're talking about supplemental oxygen. It means the patient is breathing on their own, but because of the condition, they're having a heart attack. They're having, you know, they were bleeding, they had trauma, right? They need some supplemental oxygen, extra oxygen to help them because they're not, you know, using their oxygen well. So that's where we use our non-rebreather and we use our nasal cannula, depending on the situation. Now, people always ask, when do I use a nasal cannula? When do I use a non-rebreather? Back in the day, probably up until about 5 or 6 years ago, the state said always use a non-rebreather. It gives more oxygen, it's better for the patient. That was not what medicine said. Medicine said that oxygen is a drug and it needs to be administered at the right dose. And that just like too little oxygen, right, hypoxia is dangerous to a patient. Too much oxygen or hyperoxia is dangerous to a patient. So now they always say oxygen is appropriate. So we gauge our oxygen treatment or amount of oxygen we give a patient to their pulse oximetry, okay? And a normal pulse oximetry, a normal pulse ox is 94%. What pulse ox means is that we're measuring the amount of oxygen, okay, in their blood via a device we snap onto their finger or clip onto their finger, okay? So, you know, if their pulse oximetry is 94%, but yet, you know, they're having some chest pain, they're having some discomfort, we still want to maybe give them some oxygen, but we don't need to give them 100% oxygen by a non-rebreather. We can give them less using nasal cannula. So we're still accomplishing giving them a little extra oxygen, but that, you know, we don't have to give them that heavy amount, so we can use the nasal cannula. Most patients who are conscious, not struggling to breathe, nasal cannula is going to be your first choice, okay? The patients that are really short of breath, that are struggling to breathe, you can try the non-rebreather. Now I say try because picture you were having trouble breathing, right? And you really felt scared. And I came along and I strapped a mask onto your face and I told you it's giving you 100% oxygen, but you didn't feel anything, right? You felt very little flow. Like when you practice the equipment in class, I'm hoping they're going to give everybody their own non-rebreather and you could strap it to your face to see what it feels like, or you could strap it to your partner's face and learn how to put it on. but you'll see you don't really sense much in the way of flow. So when somebody's short of breath and you put a oxygen mask over their face, their initial thing is like, oh my God, these guys are trying to kill me. Like it's not giving me that much oxygen, okay? So some people who are short of breath, they have what's called air hunger, not oxygen hunger, which means that they just want to feel that they're getting air in their body. They don't necessarily care they don't know, and they don't care what the percentage of oxygen is. So sometimes we think it confuses us. You know, here we are, they're short of breath, their pulse ox is low, and we put them on a non-rebreather, okay? And yet they rip it off and say, I can't breathe, why are you putting that on my face, okay? They want almost that the air is forced into them, and that's where CPAP comes in. CPAP gives them high concentrations of oxygen, but it pushes it into them when they breathe in, okay? That's the advantage of CPAP. The problem is it's even a bigger mask and even more claustrophobic feeling on their face. So some people tolerate it. Some people are very good at putting them on, and you could sell them on it. They're very, you know, the EMT is very comfortable. It's a tough thing. You're going to see, you know, I mean, the problem is that you're going to lack, this class lacks what some of the other classes had besides the lack of in-person, which is we used to send all the students out on a paramedic truck. We can't do that during COVID. You know, we're not having any students, any observers or anything on the paramedic trucks. So what happened is, you know, some guys would do the 10 hours and be done with it. I had people that did 100 hours because they really enjoyed being out there and seeing what's going on and treating patients. And, you know, I had people that by the end of class were operating as, you know, pretty much full-fledged EMTs without having an EMT card because they had done so much time and the paramedics trusted them and they were doing a good job and everything like that. You know, I mean, the last full class we did, you know, I had a guy call me up at 11:30 at night saying, I just got back, you know, to the hospital with the patient, and he was, you know, not breathing on a bus in Haverstraw, and I begged him for almost an hour, you know, all by myself with, you know, the paramedics telling me what to do and like just wanted to tell me all the cool stuff he did and everything. And he was so excited that, you know, he didn't realize what time it was when he called me. And I thought, oh my God, something horrible must have happened if he's calling me so late at night. So, you know, but unfortunately, you know, unless COVID disappears very quickly, but it doesn't look like it is, you know, we're not allowed to have any observers, you know, on the ambulances. So somebody just.
How are we going to do the hours on the ambulance then?
So we're allowed to do it, quote, virtually, which is a joke. We're allowed to like give you a scenario and say, okay, you know, pretend you have this patient, what would you do for it? So, you know, I know. If the state relaxes the, relaxes the rule coming up, we'll see what happens. But, you know, that's part of the problem. I mean, the other problem to tell you is that, you know, this is a huge class too. I wouldn't even know how we would squeeze everybody in, you know, with enough shifts and stuff like that, because not every paramedic wants to have a student. So, you know, it's not like I have that many people that actually want to take students, but.
Whatever it is, send me to the city.
Send you, well, if you can make arrangements on your own, you know, I mean, outside of the class, and you have friends down there that'll let you ride with them, I don't have a problem with it, but it's outside of the class because we can't do that. Okay, so somebody put a question, says, how do we get 96% oxygen when the air around us is only 21%? So you mean in the oxygen tank. So the oxygen in the oxygen tank is 100%, okay? And what happens is, again, that's a process in a you know, in a plant, in a place that does that, where they basically have machines that take in, you know, oxygen and concentrate it, you know, they take that 21% in and make it into 100% oxygen by removing all the other things that like, so air is 21% oxygen, the rest of it is nitrogen. So what they do, and I guess in the process, and I'm not 100% certain, is that they somehow pull out the nitrogen and other gases and just leave the oxygen being pure. So when we say 21% oxygen, that's 21% oxygen in the air that we're breathing, you know, on Earth. So the rest of it, most of the rest of it is nitrogen. So I would assume what they're doing is they're basically filtering air, taking out the pollution, and then removing the nitrogen and other gases and leaving with 100% oxygen and then putting that in a tank. So the oxygen we're administering to a patient is 100%. Doesn't mean the patient actually gets the 100% because obviously, depending on the device you use, there's leakage and, you know, mixing with room air and stuff like that. So, okay. Okay, so remember.
Excuse me a minute. As far as I understood from the question he asked, that how can we have in a pulse ox 96% when we breathe only 21%?
Oh, because that's referring to how much oxygen is on your hemoglobin. In other words, your hemoglobin, how much total amount of your hemoglobin has oxygen on it. So that's what it's kind of referring to. I see what you're saying. I read it wrong. Okay, so what it's talking about when you look at pulse oximetry, it's looking at how saturated is the hemoglobin on your red blood cell, right? So hemoglobin is the part of the red blood cell that carries the oxygen, and how much of that hemoglobin has oxygen, right? In other words, is 100% saturated? Is it 10% saturated? So a normal amount of saturation of oxygen on hemoglobin, okay, would be 94% or higher, okay? So your book may say a little higher, but nowadays they say 94% or higher is considered normal, okay? So that's what it's looking at. So just in other words, so let's say a hemoglobin molecule obviously has the ability to be 100% saturated. Okay, and there are patients you'll see when you put the pulse ox under 99, 100. Okay, but you know, when you look at pulse ox, we're looking at how much of that hemoglobin is filled up with oxygen. And obviously, the more of the hemoglobin has oxygen on board, the more oxygen there is to transport by the patient. Because what is the role of hemoglobin, right? It's part of your red blood cell, and it's the only part that the oxygen attaches to, and it's the only part, the only way the cell wall, right? Well, we are cells, right? Millions and billions of cells. So every cell has a wall around it. And the only way that cell wall will let oxygen in is if hemoglobin carries it in. And the other thing we said is similar to that is insulin, which is the hormone that allows sugar to enter the cell. So the only way sugar, okay, can be carried into a cell is by insulin, right? So the oxygen we know gets into the body by breathing, but to cross the bloodstream, get into the bloodstream, it crosses over into the alveoli. To get out of the bloodstream into the cells, right? To get out of the capillaries into all the cells of the body, it needs to have hemoglobin to bring it into the cell. Okay, it's like the hemoglobin is escorting it through the door, you know, into the cell. And the same thing, you could eat all the food you want, get plenty of sugar into your bloodstream, but for it to leave your bloodstream and get into a cell, it needs insulin to carry it in. Okay. Now, the only weird thing with that one, insulin, is that the brain will accept sugar without insulin. So the brain could always function even in a low insulin environment. Okay. Okay. So proper personal protective equipment, PPE, right? Personal protective equipment when managing the airway. So what do you think we need? So we're always going to say we need gloves. Okay. Do we need goggles or a face mask? Well, if somebody's going to cough or spit on us, you know, while we're sticking something in their mouth, then yes, right? Do we need a N95 mask or better? Well, sure. If they're going to cough, then it's in the air and we could breathe it in. So they need an N95 mask. So at a minimum, you need gloves, okay, a N95 or better mask, which is, you know, and when it says N95, there's also, you know, a P100 mask. So, well, it says one is 95% effective. What is 100% effective? So everybody would say, well, why would I want a 95% effective and not 100% effective? It's being able for you yourself to breathe through it, okay? So when they say how effective it is, it's really a measurement of how small of a diameter virus or bacteria can penetrate through the mask. So N95 is considered to be safe for you and allows you to get a little bit of air in yourself so you could actually breathe and work, right? If not, what's going to happen when you're trying to work is that you're going to take the mask off because you feel like you can't breathe. And then that defeats the purpose, right? If you take the mask off even for 1 second when you're around a patient, you know, say a patient has COVID, you've defeated the purpose of wearing the mask at all because it only takes a second to breathe it in. Okay, so the other thing I would add to that besides the goggles, okay, or face shield and the mask and the gloves is I would personally say if you really know you're going to be doing airway protection is to put a gown on. Okay, now, prior to COVID, we never put gowns on. It took too long. And we were always rushing to take care of patients. COVID changed that where we didn't rush anymore. The priority was for us to take care of ourselves and protect ourselves. So we always made sure we were completely protected before we went into a house where somebody had COVID. And that could mean sometimes an extra 5 minutes, right? An extra 10 minutes getting all suited up properly and stuff like that. So, you know, if you did that prior to COVID, people looked at you like you were a horrible person. If you didn't do it with COVID, people look like you're an idiot. So that COVID changed everybody's, you know, thought process on, you know, on how to treat a cardiac arrest or not a cardiac patient, you know, because of the risk of infection to the healthcare providers. And remember, there's a lot of healthcare providers who have died, you know, treating COVID patients. Okay, so when we're assessing a patient's airway, we're assessing a patient's breathing, right? That's constant, ongoing throughout the whole time you're with the patient, because it only takes a minute for things to change, okay? And if a patient is having inadequate breathing, they're not moving enough air in, right? They're breathing very shallow, they're in that respiratory failure, it's probably going to require us to ventilate the patient. If we catch it early while they're still awake and they could use the CPAP, that's a good way of preventing it from getting worse. But sometimes, you know, it's too late. We got there too late. Maybe they tried to treat themselves in the house. They were an asthmatic. They had different medications in the house and they tried to treat themselves. Now, positive pressure ventilation means we're forcing air into a patient. So that's going to be the bag valve mask, okay? The oxygen mask, the non-rebreather, the nasal cannula, that's not positive pressure because you're not forcing air into a patient. Now, why is it different from normal breathing? Because it's coming in under more force than most people breathe. And because of that, there's negative side effects, right? We could burst a hole in a lung, cause a pneumothorax, that's called. We could overpressurize the lungs, okay, and damage them. So we just have to realize that we only ventilate just till we see chest rise, okay? Now, the most appropriate method in New York State, we only have one method, which is a bag valve mask. Again, they're talking the difference between the flow restricted oxygen device and the bag valve mask. So we only have one device to do it. Okay, CPAP is not really considered positive pressure because it's not really forcing air. It requires the patient to be breathing in and it just helps them to breathe deeper. Okay, safety-wise, we said with oxygen, we always want to make sure it's not going to fall onto the ground, right? We always want to make sure it's strapped in place. We never leave a tank standing up. We never leave a tank where it could roll off or anything like that. Okay, we want to make sure there's no open flames or anything around a, you know, an oxygen tank. Okay. And then as far as appropriate delivery devices, we talked about that already. For supplemental oxygen means that it's extra oxygen, and that's a patient who's breathing on their own. So we said we have the non-rebreather and we have the nasal cannula, and maybe CPAP would fall into that category. And we'll talk more about that when we get into the respiratory emergencies. Okay, so what's the signs of respiratory distress? So we said respiratory distress is the earliest sign of breathing. So what do you think when somebody's having shortness of breath? They probably look like they're struggling to breathe. They look scared, right? They're breathing faster probably, okay? They may have some abnormal sounds, right? We talked about stridor, we talked about wheezing. So there were a lot of different abnormal sounds that we talked about, okay? But that's the early stage, right? So we get there and somebody's wheezing, we can give them a nebulizer albuterol, and hopefully wheezing is caused by bronchoconstriction, a narrowing of the bronchioles. Albuterol causes bronchodilation, so it reverses the problem. We said when they move on to respiratory failure, it means that their respiratory distress was not managed, okay? And because of that, they reverted to anaerobic metabolism, right? They weren't making good energy. They got a lot of lactic acid. They started breathing real shallow, and they didn't have good gas exchange. They weren't bringing enough oxygen. They weren't getting rid of enough carbon dioxide. We said when somebody moves into respiratory failure, their mental status has to change. So in early respiratory distress, what's the mental status? They're awake, they're scared, right? They're nervous, I can't breathe, help me. But when they move into respiratory failure, because of the drop of oxygen and the raising of the CO2, their mental status starts to go downward, starts to decline. So they start to get tired and weak and they may become unconscious. Now, for the next stage, if we can't correct respiratory failures, they go into respiratory arrest, which means they stop breathing. So there, it's clear to you that you need to use the bag valve mask. Okay, so when we use the bag valve mask to ventilate a patient, right, the BVM, bag valve mask, to ventilate a patient, the variation between 1 and 2 respirator just talks about how you make a seal with the mask. So if you're by yourself, that means you have to have one hand on half the mask, trying to get the whole mask over the patient's face, but you only have one hand to do it with while you're squeezing the bag valve mask. Okay, but if you have 2 people, then one person can hold their hands 360 degrees around, like you saw when we were looking at that picture a few minutes ago, and the other person could squeeze the bag valve mask. So if you were doing CPR in that situation, you would have 3 people. You would have the person doing chest compressions, and you'd have the 2 people operating the bag valve mask. And that's the better way to do it, okay? So somebody asked, do we use the BVM for respiratory failure? It depends if they're awake or not awake. It depends on, is it early respiratory failure? I said, if they're, you know, if it's very early in the respiratory failure stage where they're still awake, you could try to CPAP, right? That will kind of force more air into them and prevent them from going worse into it. But yes, if they're unconscious, not responding, you know, not trying to breathe well on their own, then yes, the bag valve mask would be appropriate in respiratory failure. Okay. So any question, I mean, again, I know everybody's asked questions. So just if you have questions, put it in the chat, okay, or interrupt or something like that, and, you know, we'll do it. So let's take, it's 8:44. Let's take like 5 minutes. I'll set up the next one. We're going to talk about vital signs, and then we'll pick up again. Okay, so just take a couple minutes. Okay, so somebody asked, what is CPAP, right? So let me bring up. So CPAP is basically a way of supporting somebody's ventilations. It's kind of like an oxygen mask, but it forces the oxygen a little more into the patient than an oxygen mask does. So let me do a new screen share.
Is that like a machine that you sleep with at night?
No, so ours are not like a machine. Can you see the thing that says Mercury Medical Flow Safe over here?
Yep, we see that.
Okay, so this is the one we use. The one that people use in the house is basically a machine that pumps air into either a nasal device or a mask over their face. Okay, this one works off of oxygen liter flow, right? So it's the oxygen coming out of the tank that it's running off of. And then based on the settings, we can adjust the amount of pressure we're going into the patient. So I don't know if you can make it out. Let me see if I can find a better picture, but there's a big strapping system and there's this mask. And for CPAP to work, there has to be a tight seal, because what it's basically going to do is it's going to generate a lot of pressure under the mask. And when a patient then opens their mouth to breathe in, because of this high pressure, the air is kind of forced into them. So I think this is a good picture. Let's see. Let's see if I can get this up. Okay. So we can't see his whole head, but it basically has this strapping system that goes above and below. So there's actually straps going up here. Let me see.
Why is he still using the nasal oxygen on him when he's doing the CPAP?
That's not what they're using. What they actually, we have a way of monitoring exhaled CO2 through a special nasal cannula. So that's what they're actually showing you. He may be getting some oxygen through it too, because it gives oxygen at the same time. It monitors the end-tidal CO2. So it probably is doing a little bit of both, but it's just a way so we can see how much CO2 he's putting out, which will give us an idea of, how well the CPAP is working. So it's just a way of seeing what's going on. Give me a second.
How does the CO2 leave the body at the strap mask?
So it's going it out their nose. That's why they have it on. Oh, you mean how is it exiting over here? There's a valve. In other words, so you see over here, there's a filter over a valve. That's what it comes out. We never used to use that filter, but now with COVID, we have to use the filter. So when the patient's exhaling, they're not doing it. So see this big strapping mechanism? This is how tight it's on the patient's head. And it's basically resting on their forehead up here. So it's a very, very pressurized feeling on their face. So that's, whoops. Okay, so can you see it? Is it still up the screen share? Can you see the mask strap to the, whoops.
Yeah, we see it now.
Okay. Whoops. So, so when I was saying that sometimes people feel like claustrophobic, so this guy's short of breath, right? And now you have this big device, even though it's giving them 100% oxygen and forcing it into them, some people still, panic with this over their face because they're short of breath and they're just not thinking well. So, some people love it. Some people do great on it. I mean, there's patients that literally by the time you get them to the hospital, look like they were never sick, and the hospital's looking at you, why'd you bring them in, and stuff like that. So it just really depends on how comfortable you are putting the device on, right? Because if you're futzing around and then making mistakes and stuff, then the patient's not going to tolerate it. And it depends on how cooperative the patient is, you know. And some people, like anything, they're more, they listen, they believe you when you say, let us get this on you, it's going to help you to feel better, and they believe you and let it work. So but it is a great device. I mean, prior to this, we had to intubate a lot of patients in the field, and now with this, a lot of patients, we can get to the hospital, and they actually are in pretty good shape. Okay. So let me find where the PowerPoint went to, because everything got shifted around now. Okay, so this is this. I lost everybody's pictures, but I guess that doesn't matter. Okay. Okay, so can everybody see chapter 13, vital signs? Yes? Okay. Okay, so first of all, what are vital signs? So there's many different vital signs. On an EMT level, we're looking at a patient's pulse rate, and besides how many times per minute it's beating, we're also looking at the strength of the pulse and the regularity. The regularity means how much time is between each beat. So a normal heart rate is the same time between each beat. So if your heart rate is 60, right, per minute, that means there's 1 second between each one. When the time between each beat varies, that means there's some kind of problem with the cardiac conduction system, right? The pacemaker of the heart is not sending out the impulses at a regular time. So we look at not only pulse rate, but pulse regularity, okay, and pulse strength. Does the pulse feel weak, okay, or does it feel nice and strong? We monitor respirations, okay, so same thing, we're looking at a respiratory rate, we're looking at respiratory regularity, and the only time the respirations are going to become irregular is there's an injury to the brain, because the brain is the part of the body that controls breathing. And we're looking at how deeply they're breathing, right? Because we want to have good tidal volume, so we have good gas exchange. We want to get a lot of air down to the alveoli so we can exchange the oxygen and carbon dioxide, okay? And then we monitor the blood pressure. And we've said a few times already that there's 2 numbers. Now, blood pressure reflects the pressure on the inside of the arteries when the ventricle, left ventricle, is contracting. So it's telling us how much force, okay, the blood is traveling through the arteries. And we said there's 2 numbers, is the systolic, right? And systole means the heart is contracting. So systolic is the higher number. And diastolic is when the ventricles are refilling with blood, and that is the lower number. And then pupils are considered a vital sign, even though they're really not, right? I mean, they're definitely an assessment tool, but not really a vital sign. Temperature is considered a vital sign, so it probably is, especially now in our COVID environment and stuff like that. Pulse oximetry is also considered a vital sign. So as the years have gone on, there's more and more things that we consider vital signs. Now, why do we measure them? Just like we're going to learn to do patient assessment, it helps us to try to figure out, 1, what's going on with the patient, and 2, how sick are they? Okay, so we'll talk about all of that. Now, I have to tell you, the only way you're going to get good at vital signs is to annoy your family. And you don't want to just take your blood pressure on your wife, right? You want to bother your parents. You want to take it on your kids, right? If their arms are big enough. You want to take blood pressures on as many different size patients and as many different ages of patients as possible, because that's the only way that you're going to learn, okay, how to take vital signs. If you're taking vital signs on a young, healthy person, that's not the same as taking it on an older person. So try to practice. Okay. So again, it gives us an idea of what's going on with the patient, okay? Now, the term trends over here, we don't get to do too much in EMS. Trend means that we'll be looking at vital signs over hours, right? In other words, that we're taking our first vital sign, our second, our third, or fourth, or fifth, and we're looking to see if there's changes in number over a period of time. So especially in Rockland County, where we're so close to hospitals, we don't really get time really to take maybe more than 1 or 2 sets of vital signs. So we don't really see trends too much, but trends are looking, is the vital signs getting better or the vital signs getting worse, okay? And yes, pretty much every patient, we do take vital signs, but if you have a train wreck of a patient that's dying in front of you and you're spending every second you have trying to keep them alive, they're bleeding to death, they're not breathing, right? I mean, there's multiple things you have to do, okay? You're never gonna have time to take vital signs. That is totally acceptable. Okay, but I'll just tell you, the first thing when you pull into the emergency room and they're going to see that you're bagging the patient and you're stopping their bleeding, you have a tourniquet on, they're not going to care. They're going to, first thing to say to you is, what are the vital signs? And then you just say, listen, we were too busy keeping them alive. We didn't have a chance to take any, because that is more important, right? I mean, to stop and take 3-4 minutes to take a set of vital signs when somebody's dying would be wrong. Okay, but the hospital, they don't know what it's like in the field. So, you know, so that's what that says down here. Patient severity, in other words, how bad are they? And treatment priorities, you're doing things to keep them alive, may prevent acquisition. It's just a fancy way of saying that when you have that train wreck of a patient, it's totally acceptable not to do vital signs on them. Okay, so we said pulse, respiration, and we're going to go over this again in more detail. Skin color, temperature, and moisture. Condition is moisture. Okay, and then in kids, we also measure capillary refill. I'll talk about that. We look at their pupils and we get their blood pressure. Now, on the test, there's going to be a question, I think there already was when we practiced. What are the baseline set of vitals, right? In other words, so the baseline set of vitals are the first set of vitals that we compare all other sets of vital signs to. So it's all it means is the first set you got, and it's your baseline. It's the first thing that you have to compare other sets of vital signs to. Okay. So again, we repeat vital signs if we can. Okay, and we look to establish trends, even though in Rockland County we can't. And trending means that you're looking at vital signs over a period of time to see if you can see whether the patient's getting better or worse. Okay.
That's 5 minutes, every 5 minutes, correct?
So again, we'll talk about that. I don't know anybody who takes vital signs every 5 minutes. Okay, but on a test question, we'll talk about that. So on a test, they say every 5 minutes for an unstable patient, every 15 minutes for a stable patient. But trust me that if you had that unstable a patient, you're not going to have time every 5 minutes. So on a test, you would answer that, but in real life, you'd never have time to do that. Okay, so what is the pulse? The pulse is the pressure wave that you feel, okay, in an artery because the left ventricle is pushing blood out into the aorta. So the aorta is the first artery, and you're feeling basically that pressure wave of blood that started at the left ventricle, went into the aorta, and is traveling through every artery of the body. Okay, so obviously, the larger the artery, the closer it is to the heart, the stronger it's going to be because you just happen to be closer to where the pump started pumping. Okay, so that's all a pulse is. It's the forcing of blood into an artery, and you feel that over an artery that you're able to press against a bone. Okay, or press against something solid so you could actually feel it. So any artery in the body has a pulse, but the closer it is to the heart and the larger it is, the easier it is to find it and the stronger it'll feel. Okay, so you're basically pressing with your fingertips. They say not to use your thumb because it has a pulse, but really every one of your fingers has an artery in it, so every one of your fingers has a pulse. But they say the thumb is a larger artery and you may feel it pulsating. If you've ever banged your finger, you do feel the pulsation in it and stuff like that, but I don't think it necessarily matters which finger you're using. I mean, I don't typically use my thumb, but I don't think it really matters that much. Okay, so we said that we're going to assess pulse quality and rate. Okay, now how long do you check it for? So some people check it because you have to measure it for a minute, right? So nobody really counts it for a whole minute unless the pulse is irregular. So irregular means that it's not falling at a regular interval. So if it's irregular, the only way you can get an accurate measurement is to measure it for a whole minute because it's not falling on a regular time frame. But if it's nice and regular, and how do you tell it's regular or not? You'll feel that after a while just by, checking it and feeling that it's going boom, boom, boom. You get that sense of doing it, with practice. So some people do it for 15 seconds if it's regular and times it by 4 because 15 times 4 is 60 and there's 60 seconds in a minute, okay? Some people do it for 30 seconds and times it by 2. So however you prefer to do it, it's fine, okay? What you shouldn't do is depend on getting a heart rate number, right? So this is pulse rate. A heart rate number is something a machine gives you. So the pulse oximetry can give you a heart rate. The EKG machine can give you a heart rate, okay? That's not the same as a pulse rate. A heart rate is saying electrically, how many times, okay, is there an impulse going out, okay? When you check a pulse rate, you're not only getting a number of how many times the heart is contracting, but you're getting an idea if it's regular or irregular. Remember, a pulse ox will not tell you if it's regular or irregular, okay? And it's also telling you the strength. In other words, how strong does it feel so you can get an idea of how well the perfusion is, okay? So yes, after you get your first set of vital signs, maybe you'll glance over at the pulse ox and get an idea of what the heart rate is based on that. And if it matches what you got manually by feeling it, then you could trust it, okay? But you should always take at least one, if not more sets hands-on, not depending on a machine to do it, okay?
That's a small thing you stick on your finger, right?
Yep. I'll show you in a second. Again, the small little one you stick on your finger, that costs $15. Again, the reliability of it is always in question, although I have to say, you know, we bought a whole bunch of those cheapo ones during COVID just to have extras. And then we compared it to our, you know, $5,000 ones, and they were not that far off. So if you get the ones that actually have FDA, you know, approval, they're not really, they're pretty good for, you know, $15 versus $1,000. Okay, so again, pulse rate is the number of beats per minute that a heart is beating, and a normal rate for an adult, somewhere 60 to 100 beats per minute. Okay, I would say most normal, you should be probably 60 to 80, you know, ideally being in your 60s and 70s would be better, because the more physically in shape you are, the slower your heart has to beat to keep you alive. So if you're checking your pulse rate when you're sitting down and your pulse rate is, you know, 90, 100 beats per minute, it means you're not in good shape, okay? So you have to get up and start walking around and, you know, moving around during the day. And you'll see even a month of, you know, walking a couple times a day for say 15 minutes at a time, you'll see your heart rate will start dropping. You'll find it easier to breathe. You'll lose some weight, okay? And you'll overall feel better. Now, we talked before that the term tachy means fast. So tachycardia, cardia meaning heart, means a heart rate above 100, and brady means slow. So bradycardia is, you know, 60 beats per minute is considered bradycardia. Actually, I just remembered that somebody had a question on the chat and I didn't see it. Hold on. Oh, so somebody asked, does the CPAP help keep the alveoli open? So the answer is yes, right? Anytime you are breathing shallow, your alveoli are not going to be as open as when you're breathing deeply. So CPAP helps people keep their alveoli expanded. It helps them keep their bronchioles expanded, right? They're air tubes. It keeps everything in their airway expanded because the air that's coming in is under higher pressure than if you were just breathing on your own. But that's a good question. Okay. If you ask me a question, I don't answer it, then just unmute yourselves. Okay, so heart rates above, I would probably make this more like 150, okay, than 120, okay? But, you know, faster heart rates need to be investigated. In other words, is somebody just nervous, or is there a reason why their heart is beating faster that we have to explore? So I'd probably make that more like 150 than 120. But yes, heart rates below 50, unless you're in good shape, like you could find people who exercise every day, who run every day, bicycle or something, and their resting heart rate could literally be in the 50s. That's just normal for them because they're in good shape. But if you looked at most of our heart rates and it was in the 50s, it's just beating too slow to keep us well perfused. So we're actually going to feel weak and dizzy. Okay. Okay. When you have patients calling you to the house because they have a medical problem, they're short of breath or whatever it be, and they're scared. Remember, whenever you're scared, adrenaline is released into your bloodstream. If adrenaline is released into your bloodstream, that's your emergency hormone, right? That's the sympathetic fight or flight response, the part of the autonomic nervous system that speeds things up. So it's not uncommon, right, for people that are scared and feel like something's wrong with them to have heart rates in the 90s and hundreds and so on, right? So you have to look at those numbers and say, why is it? Is it just because the person's nervous and scared? Or what's going on? I had a guy with a nosebleed the other day whose blood pressure was high, his pulse rate was high, and his nose was bleeding, and I couldn't stop it. So I said to him, you know, you're making yourself crazy over this nosebleed, and you're making your blood pressure higher because you're nervous. So let's try to do some, you know, close your eyes and let's start trying to do some breathing exercises. You know, so you have them basically breathe. Let me think now. Breathe in through your nose and out through your mouth for like a minute or two. And if you were monitoring your heart rate and you did a minute of, hold it for a second, your heart rate will definitely drop 10 points or so. So, you know, with that and calming him down and talking to him, he actually was a Jewish guy, not religious, in a assisted living up in Tuxedo, but he actually had a picture of his bar mitzvah from like 80 years ago. And one of those old style pictures, and he was wearing this very interesting getup and everything like that. So I said, you know, is that your bar mitzvah picture? And he goes, yeah. And I said, oh, well, you know, tell me about it. And he started talking a little bit about it and stuff like that. And by the time the ambulance showed up, his pressure that originally was 188 was down to like 160. Okay, his heart rate was down in the 80s. His nosebleed had stopped. And, he's feeling much better. He was actually feeling so much better. He said, do I really need to go? And I said, yes, because it's 9:30 at night. And I don't want you to call me at 1 o'clock in the morning and tell me your nose is bleeding again. So we sent them off. Okay, so what normal situations might account for a heart rate outside of a normal range? So we said on the low side, it means that they're in good shape. Okay, that's really the only reason, okay, that they're in good shape. Actually, let me take that back. There's one other reason why somebody will have a slow heart rate. There is a type of medication used to control blood pressure called beta blockers, BETA, beta blockers, okay? So when it says a beta blocker, it means it's blocking beta. Beta is the part of the heart that speeds things up, okay? So when you give them a beta blocker, it's slowing down their heart rate. You may have heard some of the terms Inderal, propranolol, atenolol. They're medications that end in LOL or AL, right? Those are the last letters. And they work to lower blood pressure by slowing the heart rate and slowing the strength of the contraction. So they're going to slow the amount of times the heart beats per minute and how hard it squeezes. And by doing those two things, it lowers the blood pressure. So you could go to somebody's house that's on that medication and see their heart rate is 62 and they're, I don't know, 80 years old. And you say, well, it's not normal for an 82-year-old to have a heart rate of 62. Doesn't look like they're an active, runner type of person. I wonder why it is. And it's just the medication they're on. Okay. And we'll talk about how medications help us with our assessment and how medications may mask our assessment. Like, in other words, a patient that's on that beta blocker, and let's say they start going into shock. We said one of the early signs of shock would mean they're getting tachycardic, right? And that's how their heart's trying to compensate. Well, because they're on the beta blocker, they can't get tachycardic. So now we kind of miss that diagnosis sign. And also, they're not going to compensate and do as well because they're on that beta blocker. The other thing that beta blockers interfere with is a patient having a severe allergic reaction, anaphylaxis, they give epinephrine to, because epinephrine is a positive beta drug, and a beta blocker blocks those effects. So no doctor will put a patient with a history of allergies on a beta blocker. It's contraindicated, right? It's a dangerous thing to do, but maybe the patient didn't know they had any allergies, and they're put on a beta blocker.
Isn't beta blocker a general term also used
Yes.
for cancer treatment?
I don't know if they use beta blockers for cancer treatments, to be honest with you.
Advanced treatments, not chemo, but advanced therapeutic, like forgot whatever out of the chemo regimens.
Could be. It could be. I mean, I don't really know much about cancer treatments or anything like that. It could be. They always look to see if there's existing medications that maybe have other uses and stuff. I mean, we saw that with COVID, right? I mean, they were, experimenting with all these different medicines that had, other uses to see if they might help in COVID because they didn't know what to do with it. So, okay. So then we said, the pulse quality, right? There's the pulse rate, and then there's the idea of like, how well is it breathing? So one thing we said is rhythm, right? Is it breathing at the same interval? In other words, like if the heart is beating 60 times a minute, it should be a 1 second interval between each heartbeat, right? So if not, that's telling you there's a problem with the cardiac conduction system, okay? And then also, how is the force of it? In other words, does it feel nice and strong, okay? Or is it what they call it tready or weak? So tready and weak means that you could barely feel it. Now, remember, if you were to check your wife's pulse and she weighs 100 pounds and she's a tiny little person, she's going to have a weak pulse because it doesn't take a lot to push blood through her body because she's small. So you always have to take it into, account of what the situation is and stuff like that. Okay, so where do we look for pulses? So the most common place we check for a pulse in a patient, okay, who's, over about 1 year of age and is conscious, alert, talking to us, in other words, they're not dead, is the radial pulse. The radial pulse is on the lateral side of the wrist, right? So the lateral side of the wrist is the thumb side of the wrist. You do have a pulse on your medial side. That's your ulnar pulse, right? Because you have an ulnar bone and a radial bone, right? So it's referring to the artery in the bone by the same name, which usually happens, right? And all you're doing is pressing it down on your radial bone, right? So your radial pulse overlies your radial bone, your radius bone, and you're pressing it down on there to feel it, okay? So that's the more typical way that we do it. Now, while this person is doing this, okay, he's probably going to continue to hold the guy's wrist and then start counting his breathing. There's a weird thing, we all do it. that if the doctor were to tell us, or the paramedic or the EMT were to tell us, I'm counting your breathing, we would slow down our breathing subconsciously. We would just do it because somehow we think slower is better. Okay. So if you tell a patient, I'm going to count your breathing now, they're guaranteed to slow down their breathing. So the way to kind of fake them out is to do it while you're checking their pulse. Just keep your hand on their wrist and just keep an eye on how often they're breathing by looking at how much their chest is moving. The typical easiest place to see breathing is by the diaphragm. Okay, so that's usually because that's the muscle that moves the most when you're breathing. Oops. Something's wrong. Okay. So the brachial pulse is on the inside of the arm. It comes out from your armpit, from your axillary area, and goes down to about your elbow, and then it splits into your radius and ulnar artery, right? So one goes to the lateral side, one goes to the medial side. The reason they say to check a brachial pulse in kids is that you see how the kid's head is kind of sitting right on their chest. It's very hard to get your fingers in there and find a carotid pulse. Okay, so it is, an acceptable pulse site to find. It's hard. I always look for it, but if I can't feel it, I take my stethoscope and I put it right over the chest where this person's hand is and listen for what they call the apical, A-P-I-C-A, apical pulse, which is you're not really feeling a pulse, but you're listening for the heart rate. Okay, and if you hear the heart contracting, pounding, you know that there is a heartbeat. Okay, and then on an unconscious patient, we typically look for the carotid pulse. Now you have a carotid artery on both sides of your neck, okay? And, those are the large arteries, on either side of your neck, okay? And I could have sworn I saved a picture today in here, but I don't know where it went to. Okay, so again, most people do pulses for 30 seconds and times it by 2. But if it's not a regular rhythm, then do it for a full 60 seconds. Okay, this way you get an accurate count. Okay, so respirations again are counting the amount of time a patient's breathing. Okay, and we're going to look at the rate and how deep they're breathing. Okay.
My apologies.
Okay, so we can say a patient's breathing a normal respiratory rate, which is about 12 to 20. Okay, or they're breathing rapid or slow. Okay. I don't know what's going on here. What's going on here? Okay. So again, 12 to 20 is normal, but that's at a person at rest, right? So again, if we go there, they're going to probably be scared. They may be breathing quicker, okay? They define quicker as around 24, okay, breaths, and slow is below 8 breaths per minute, okay? And again, as far as serious findings, it really depends on what is the problem with the patient. So you don't base your decision on what's wrong with the patient just on one set of vital signs. You're going to take a history, talk to them. There's other things that we're going to assess with them, okay? So when we talk about the quality of breathing, normal is what we're doing right now, breathing in and out regularly, nice and deep. Shallow means you're not breathing deep. Labored means it looks like they're having trouble breathing. And noisy means that you hear sounds. You hear wheezing, you hear rhonchi, you hear some kind of sound, and we'll talk about all the abnormal sounds when we do respiratory emergencies, okay, when they're breathing. Okay.
Can an EMT give albuterol?
Yes. And they've actually expanded. It used to be that a patient had to have a history of asthma and be between the ages of 1 and 65. Now they just changed the protocol to say that anybody who's wheezing, no matter what their age is and whether or not they have a history of asthma, can be treated. Okay, and they've increased the amount of dosages that you give to 3. So they've really expanded, BLS use of albuterol.
What is it, albuterol? And there's one more thing that you give.
Nope, EMT, just albuterol.
Got it.
Yep. So I don't know why, to be honest with you. They should allow EMTs to use both medications, but they only allow them to use the albuterol.
What's the other one? What is that called?
Atrovert or ibuprofen. Depends on whether it's generic or name. It's Atrovert is
It's
one
a
name.
steroid.
No, albuterol is a sympathetic medication and the other one's a parasympathetic medication. There's other medications that are steroids, but when you give medicines for breathing problems, there's what they call rescue medicines and there's what they call maintenance medications. So maintenance medications prevent patients from having breathing problems. Rescue medications are when they're having the breathing problems. So now steroids are not a big medication used in breathing problems because long-term use of steroids, can be dangerous to the body. So maybe for a month or two, they might be people on steroids, but they, years ago, people were on steroids for, asthmatics for years and years and years, but, there were lots of problems, bone problems, hair falling out, all kinds of crazy problems. So, they don't routinely give a lot of steroids anymore for breathing problems.
Frank, can you give albuterol for CHF?
So it's not going to probably help a CHFer who has albuterol. CHF means congestive heart failure. It means that the heart can't pump out well because it's been damaged. So fluid, the plasma is backing up into the lungs. I'll explain it obviously when we get to the cardiac section. So really the treatment nowadays for CHF for an EMT is to put them on CPAP, because what CPAP does is helps to get the air through the water back into the alveoli. So it's.
But is it safe to suspect? Do I have to suspect that the wheeze is a cardiac wheeze?
So it's very rare. That whole concept. I mean, I don't want to get into it tonight. When we do cardiac, we'll talk about it. But sometimes CHFers do have a little wheeze. But what it means is that their alveoli are so full of water that it's actually coming out of the sac and touching their bronchioles. And that's where the wheeze is coming. So, but it's so rare. And really the treatment, it's more important to get air into their alveoli than it is anything else.
I'm still gonna go with albuterol, right?
No. In a CHFer, you're going to go with CPAP. That's our main treatment for CHF on a BLS level.
Right.
Okay, so now skin color, temperature, and condition talks about moisture. So skin should be pink, it should be warm, and it should be dry, right? That's what normal skin is right now. We should all have pink, okay, warm, dry skin. People who work indoors a lot and not outdoors, they have pale skin just because they don't get exposed to a lot of sun, but that's not the pale of like somebody going into shock because they're not getting good blood flow, right? So, as we talk about the different emergencies, we'll talk about the different colors and stuff like that, but we mentioned cyanosis, right, as being a bluish discolorization, typically seen over what they call mucous membranes. Mucous membranes are where the skin is very thin. So the most visible mucous membrane is the lips, right? The skin is very thin over the lips. So it's very easy to see color changes, over the lips. You've all seen blue lips when kids were in the swimming pool and they got cold. That lack of oxygen in their lips in that situation wasn't caused by a breathing problem. It was caused because when they're cold, the body doesn't send warm blood to the surface of the skin. So if there's no blood going to the surface, there's no oxygen going to the surface. So that's why they get those blue lips. But that's the same color blue you would see in someone, okay, who was not ventilating well. Okay. So again, where's best to see color? So I don't know, to be honest with you. It really depends on the color of the patient, right? Dark-skinned people are harder. You could look anywhere, to be honest with you. I don't ever look at the inside of somebody's cheek, right? The inside of the mouth, because you can't see it. If you peel back the eyelid a little bit, look at the lower eyelids, you can get an idea of color, okay? The nail beds, again, capillary refill. So, it's really almost anywhere in the body you can check color. So I put some colors here, right? So pale skin could be one, just, you're not outdoors a lot, okay? Very common in the Jewish community that people are pale just from not getting, out in sunlight, or not working outside and stuff like that. Okay, but pale could mean somebody who's cold or somebody who's in shock, right? Cyanotic, that bluish grayish discolorization, typically indicates hypoxia. But again, if it was somebody out in the cold, it could just be that. Flush skin, where they're bright red, looks like, when you saw your kid with a temperature, with a fever, right? So it's either that they're having a heat emergency that we'll talk about when we do environmental emergencies, right? Heat stroke, heat exhaustion, and stuff like that. They're trying to get rid of extra heat. So when you try to get rid of internal heat, your body dilates all the blood vessels. So your skin on the surface looks very red because it's bringing all that blood to the surface. Dilation means that the blood vessels are getting bigger, and constriction means that the blood vessels are getting smaller, right? Or a fever, right? You're having an infection, and again, you're getting warm, so your body dilates your blood vessels. Now, the term cherry red or fire engine red is reserved for carbon monoxide poisoning. It's not a sign you'll see typically unless the patient is dead already. But what happens in carbon monoxide poisoning is we said that the oxygen can't get on the hemoglobin because the hemoglobin likes carbon monoxide better, right? Carbon monoxide is a waste product of what they call burning of carbon, like paper and wood and fuels, propane and gasoline. It's the waste product when you burn, carbon material. So when somebody has carbon monoxide poisoning, what happens is the carbon monoxide gets onto the hemoglobin and coats it, and there's no place for the oxygen to get onto. Now, you still have plenty of oxygen in your bloodstream, but it can't get on the hemoglobin to get into the cells. So the cells die and you die. But the bloodstream has plenty of oxygen in it. It just can't get into the cells. So now after the patient dies, all that oxygen comes to the surface and they look very, very red. Okay, and I'll show you pictures of what that looks like. And jaundiced or yellow skin, okay, you could sometimes see in, premature babies where they have to go under the lights and stuff like that. But jaundice is telling you there's a problem with the liver, okay? So the most common problem with the liver is hepatitis. You could also have people who drink a lot or alcoholics that have damage with their liver, get cirrhosis of the liver because the liver breaks down the alcohol. And if you're constantly, have a lot of alcohol, you overtax the liver. So jaundice is a sign. There can be a test question that says, where's the first place you see the yellow color? And that's the white of the eyes. The white of the eyes is called sclera. And the first place you see the yellowness that come out is in the white of the eyes. Okay, so temperature. So we used to
interrupting. So that means if someone has yellow eyes, that's something wrong with the liver. Is that what it is?
Yes, but in kids, it's not that there's actually something wrong with it. It just means that the liver is not mature enough yet. It will be, in other words, most of the times it just takes a couple more days. So I wouldn't think it's a real emergency. But if you see it in an adult, yes, there's definitely some problem, going on with the liver.
And when you say in kids, it's not such an emergency, it's only newborns, right? Not too big.
Oh yes, I'm sorry. Yeah, I'm talking newborns. I mean, yeah, if you see somebody say beyond 30 days, yellow, then it would definitely be an issue, right? Bilirubin is, somebody says that's bilirubin. So bilirubin is the substance, right? The waste product that's given off by the liver when it breaks down things. So as it accumulates, it's not getting rid of, you turn yellow. That's the problem. You normally would just get rid of it, so we never see it. So that's the issue there.
If you eat a lot of carrots, they'll cause your skin to turn yellow and your eyes. My wife had it. They were afraid something was wrong with her liver. And every time she was eating a lot of carrots, and then literally it changed her skin.
Really?
They made her go get blood tests and all kinds of stuff because
wow.
of that. Yeah.
I never heard that. But just one thing with the little kids, just because this happens really only in the Jewish world, but you may get a call with a brand new little baby girl, first month, and they're going to call you and say she's bleeding from her vagina. Okay, so it really isn't that she has any problems, but what happened is that it's not a lot of little girls, but the hormones, the same hormones that call menstruation in women, sometimes, are high in newborn babies if they cross over from the mother into the baby. And the baby has almost like a little menstrual cycle, like a little period. Usually only happens once, and it's done. But, what's going to happen is the mother or father is going to be changing the diaper and they're going to see some blood in it and they're going to freak out. And, in the non-Jewish world, they call the pediatrician. The pediatrician tells them, don't worry about it. In the Jewish world, they call Hatzola. So you're going to get, you're going to get this phone call. They're not going to want to tell you anything, or they're going to want to tell it to you privately because they're all embarrassed thinking there's something wrong with the kid. But it's really not an emergency. Okay. So I usually just tell them, let's call the pediatrician, have the pediatrician talk to you, and they'll decide whether or not, they want the baby to go to the hospital, but it's not really an emergency. Okay, so this is the way we used to take temperature, but now we use obviously thermometers. We use electronic thermometers because we don't want to touch patients anymore. So we used to peel back our glove and put it on their forehead and feel their temperature and stuff like that. Again, another change since COVID. Everybody has multiple thermometers, everywhere on the ambulances. So we don't touch patients anymore to feel their temperature, but that's the way that we used to do it. Okay, so capillary refill. I think I showed it to you, which was everybody could take their hand right now and push down over here for a second, pull it away. It'll go from very light color to blood coming back. So when you push down on a surface, you're pushing the blood out of the capillaries, and then you want to see how fast it refills. Okay, so some books say less than 2 seconds. Some books say less than 3 seconds. On the EMT exam in New York State, it uses 2 seconds. They'll say less than 2 seconds, or the time it says to say capillary refill is a normal capillary refill. If it's longer than 2 seconds, then it's considered prolonged. So obviously, if it's longer than 2 seconds, the feeling is there might not be good perfusion, right? That there's a delay in the capillaries refilling. Some people do it on the nails. Same thing. You push down on a nail, pull it away, and when you push down, pushes the blood out. You take your finger away. It's pale and then it pinks right back up. So now, so they say for kids under 6. So the reason why is that in adults, we have so many capillaries, right? So well distributed through our body that they consider capillary refill to be a very, very late sign. But in kids who obviously are not as developed as adults, they don't have as many capillaries. So in kids under 6, they consider it to be a somewhat reliable sign. Okay, so the center of your eye is called the pupil of your eye, right? And the pupil is basically a lens that opens and closes depending on the amount of light. When there's bright light, it closes. When it's dark, it opens. It's kind of like the shutter on a camera, right? So it does the same thing. So it controls the amount of light coming in and out, okay? So one way we kind of assess patients is how well do their pupils dilate, okay? Now, the first thing is that a pupil should dilate when you shine a light on it, okay? So if it doesn't, we have to suspect that there's something going on, usually in the brain, okay? But also, if somebody starts to get shocky and they're not perfusing their brain well because they don't have a good blood pressure, not pumping a lot of blood up to their brain, you may see pupils that dilate slowly, okay? So again, in dim light or dark light, the pupils will dilate, and in bright lights, the pupils will constrict. Most people use a pen light, and they'll shine a pen light in the patient's eye. But you could accomplish the same thing by, like, let's say a patient's in a room that has lights on, okay? So you really can't get that pupil to constrict anymore. So all you have to do is shade the eye, all right? And you'll watch it get bigger, and then you pull it away and you watch it get smaller. Okay, so that's all it is. Now, both pupils should be of the same size, okay? And interestingly, when you shade one pupil, the other one does the same thing a lot of times. So it's like a sympathetic, like you move an eye in one direction, the other eye moves, it's sympathetic. They both do it, okay? So, you know, we assess pupils, but there are some people who normally have abnormal pupils, and also people who have had cataract surgery will have abnormal pupils. They will not be reactive, and they will not be of the normal roundness, right? So, you know, if you have a patient conversing with you and you see their pupils are not reactive and are not of the same size, it doesn't mean that there's anything wrong with them if they're talking to you normally, because typically pupils not responding or a brain injury. So, but if they're talking to you normally, they don't have a brain injury. Oh, somebody wrote a question. Let's see. Oh, great question. So you guys are thinking ahead. What would be the pulse oximetry reading on a patient with CO poisoning, since the body has regular amounts of oxygen but not in the cells? So it's a great question. So pulse oxes are totally unreliable in CO2 poisoning. What you'll actually get is a perfect number, because pulse ox looks at the amount of oxygen in the blood. And in the blood, it's fine, but it can't get into the cell. So the patient's still dying from cellular, cell level hypoxia, okay? But their bloodstream is fine. So we never use a pulse ox, or anybody who has half a brain would not use a pulse ox on a patient who has CO poisoning. Now we have a device that looks like the pulse ox that's designed to measure CO. It's called a RAD, R-A-D, RAD57. I don't know how they came up with that name. So that's a device that does both pulse oximetry and CO. So when we have a suspected carbon monoxide poisoning, we put them on that. Okay, so I'll show you that. I'll bring one in one day. They're about.
I think that paramedics can see in the monitor if the patient is CO.
So you can have built in, depending on the heart monitor you have, you can have that same function built in. You just have to change the probe that we normally use for pulse ox to a much more expensive one, like a $1,500 probe. So they don't usually leave it on there. But yes, you know, LifePak 15s have it, and you know, a lot of the other ones have it built in. So, but you know, on the BLS level, you're not going to have that piece of machinery. So the county in Rockland County, the county gave every ambulance corps one of the RAD 57s, and so most of the ambulance corps went out and bought more. Okay, so we're assessing pupils. We want to look at the size, the quality, and reactivity. In all honesty, all we're really looking at is, are the pupils the same size? You know, the same shape, same size, and do they respond to light? That's what we're kind of looking at. So they're showing you tiny little pictures. Don't worry about it and stuff. But you know, if you look at enough people's eyes, you'll get an idea of what their pupils look like. I mean, you probably already know it, you know, from what you're doing and stuff. Now, a small population of the patients have where one pupil is bigger and one is not, okay? and that's called anoscoria. You don't need to know the name, but so if you look at somebody, this guy's talking to you, he's wide awake, and you say to him, do you know that have the doctors ever told you that you have two different size, your pupils are of different size? And he says yes. That means he knows he has the condition. It's not anything wrong. It's just the way he was born. Okay. The same thing that could happen if somebody went for an eye exam, they give you medication to dilate your pupils, right? That's why you have to wear sunglasses when you go outside after an eye exam. The sun bothers your eyes because your pupils are so dilated. Normally they would constrict when you go outside, but because the drops are in there, they're forcing them open typically for like an hour or two. So you have to walk out with like sunglasses on. So again, if somebody got into a car accident and they just left the eye doctor's appointment, you're going to have people who have abnormally dilated pupils. Okay, so blood pressure is not that you're feeling the pulsation on the wall of the artery like a pulse is, but you're actually measuring the pressure of the blood being pushed on the wall, right? So we said that you have a systolic and diastolic. Systolic refers to systole, which is the contraction of the heart, so it's the higher number, and diastolic refers to diastole, which is the refilling of the heart, the refilling of the ventricles, so it's the lower number. Now, I wrote 120/80 here. So years ago, that was considered normal blood pressure. Nowadays, it's 110/70, but on your state exam, it's still 120/80, okay? So, but if you went to the doctor with 120/80, he'd say, you got to exercise, you got to cut down on your salt, you got to watch your blood pressure. It's starting to get high. So the new normal is 110/70, okay? Okay, so there's two ways to measure a blood pressure. There's one by auscultation, and we said that's always going to be on the test. Auscultation is listening, and there's one by palpation or feeling. So either one, you have to use a blood pressure cuff. So this I broke out the word here for blood pressure cuff, but this sphygmomanometer, okay, is the medical term for a blood pressure cuff. The only reason I put it out is that they could have that word on the test. I'm not going to ask you to pronounce it, but they could have that on the test, right? So I just wanted you to see it, there. And you need to, so for auscultation, you're going to need both the blood pressure cuff and the stethoscope because you have to listen. For palpation, you only need the blood pressure cuff, okay? So in class, they'll show you how to put the blood pressure cuff on. Okay, so you're going to be going above the crease of the elbow, and you need to leave about 1 inch to 1.5 inches above the crease of the elbow because you need to have a place to, hold on 1 second, somebody wants to get in. You need to have a place to get the head of the stethoscope down on a patient's arm. And what you're basically doing when you put a blood pressure cuff on is like a tourniquet. You're shutting the blood flow off in that artery, and then you're listening at what kind of pressure it needs to reopen it, okay? So that's kind of what a blood pressure, in fact, a blood pressure cuff could be used as a tourniquet in severe bleeding. The problem is that blood pressure cuffs don't always hold the air inside of them well. That's why we don't use them. So you could put it on, inflate it, and then, we could start actually losing the pressure, especially old blood pressure cuffs and stuff like that. Now, when you put a blood pressure cuff on, it's obviously being held on by Velcro. There's a lot of different size blood pressure cuffs. So you'll learn to, look at the patient and choose the right size. We have cuffs that we call thigh cuffs that are used for very obese patients because they're big enough to go around the patient's thigh. So it's considered a nicer way of saying the patient's fat and you have to use a bigger blood pressure cuff than saying, you have to give me the, the elephant sized blood pressure cuff. Now, two weird things with blood pressure cuffs. If you have to stretch it to make the Velcro meet, and then you take that blood pressure, it's going to be abnormally high. And if the cuff's so low that you actually had to put some, the cuff is so loose that you actually had to put air into it to get it to hold on to the patient's arm so you could take their blood pressure, you're going to get a low reading, okay? Now, you should wait a couple minutes between blood pressure readings in the same arm. So if you're taking a blood pressure in the right arm, you should probably wait at least a minute before you take it again, because what happened is you put a lot of pressure on that arm, so the arm is going to kind of be a little swollen. And if you keep on taking repeated blood pressures, the blood pressures are going to be chronically, or abnormally high than you normally would get, because it's just going to be harder to push the blood through at each successive time. Okay, so you need to have the gauge facing towards you, okay, so you could see it. When you practice with the blood pressure cuff in class, there's a bladder in here that when you squeeze a cuff, squeeze a bulb, you're putting air in the bladder. the bladder should line up pretty much over the brachial artery, right? So we said the brachial artery is coming down over here. And then we need about an inch above the crease of the elbow to be able to put our stethoscope over the brachial artery. The brachial artery is on the inside of the arm, okay? And you'll see there's markings where it says where you should line up this arrow if it's on the left arm and where you should line up this arrow on the right arm. And what you're doing is you're centering that bladder over the brachial artery by doing that, okay? So again, we said we're going to wrap it around, cuff about a 1 inch, 1.5 inches above, depending on how big the head of your stethoscope is. And you want to center the bladder over it, okay? You're going to tell the patient what you're doing, especially if they don't know, especially if it's a young patient, that it's going to feel a little tight for a second, okay? And there's a right way and a wrong way to do it, okay? So the right way to do it is that you would not bother putting your stethoscope in place. You would put your blood pressure cuff in place. You'd put your hand on the, really, I do the radial artery, okay? And then you're going to start inflating the blood pressure cuff until you completely shut off the radial pulse, okay? Then you're going to take your stethoscope and put it over the brachial artery, and you're going to slowly start taking the pressure out. And when you hear a tapping noise, that is the systolic blood pressure. And when the tapping noise goes away, that is the diastolic blood pressure, okay? And you're going to hear that through your stethoscope. Now, depending on how good your ears are and how good your stethoscope is, you may notice a difference in the sound about halfway down. In other words, it's going to be dead quiet. Then you're going to start hearing a loud tapping sound, okay? And then the tapping sound is going to change, okay, a tiny little bit, get a little lower, and then it's going to go away. So we don't have to worry about when the sound changes, and most of us don't hear it because we don't have a good quality stethoscope, okay? But, you know, you may have good hearing and a good quality stethoscope, you may hear it. Don't worry about it. It doesn't pertain to what you're doing as far as the blood pressure, okay? So you want to know when you first hear it and when it goes away. So while you're doing that, you're going to be looking at the gauge, and you're going to note the number when you first hear the tapping sound, and you're going to note the number when the tapping sound goes away, okay? And that's the two numbers that you would be most interested in, okay? So they're showing you palpating for the brachial pulse, so you know where to put it, right? And you see this is where he feels the pulse. This is on his right arm, so he's getting the arrow to line up with where he feels the pulse. Okay, so you're going to, once you line it up right, you're going to inflate the cuff, okay? And then to get the systolic blood pressure to higher one, you're going to slowly release the pressure. And this is something you have to practice in class, and you actually have to get a feel for. One of the most common mistakes new EMTs make is they let the air out too quick, right? So you want to let the air out slow and steady so you could actually have time to hear the noises. And again, the first tapping noise you hear, and you're going to look at the cuff and look at the gauge and note what the number is, and that's your systolic. You're going to continue, okay, to let it out, okay? And when the sound goes completely away, that is your diastolic, okay? And you're going to just make note of that. Now, palpation takes the stethoscope out of the equation. Palpation will only give you the systolic blood pressure, will not give you the diastolic blood pressure. And what you basically do is you put the blood pressure in place, you find a radial pulse in the hand on the side of the arm you used, right? So you're using a right arm, right radial pulse, okay? And you're going to inflate the blood pressure cuff until the blood pressure, until the radial pulse goes away. And then you're gonna, once it goes away, I usually give it one more squeeze after it goes away, okay? And then you're gonna slowly let the pressure out. And when you feel the radial pulse again in the wrist, that is the systolic blood pressure. Now, typically the systolic blood pressure by auscultation, by listening, you'll get about 10 points higher than by palpation. Okay, so just so you know. So if you check it both ways, it's normally going to be a little higher by auscultation because you hear it earlier than you feel it. Okay, so we typically don't do blood pressures on small kids. Definitely under 3 years of age, I wouldn't do them. Okay, and you know, we don't. It's not really. Again, it's not something you have to do. It's going to make them freak them out, make them cry. It doesn't really pertain to problems that we typically have with kids. Most problems in kids are respiratory in nature and not blood pressure in nature. Okay, automatic blood pressure machines. So, you know, the ones in the store, I don't know how accurate they are, but you know, the ones that are built into our medical equipment are pretty accurate. So they're actually probably accurate, more accurate than a lot of our ears. So it's fine to use the ones, you know, that are built into the machines and stuff like that. These, a lot of times we go on EMS calls because patients buy these and they take their blood pressure and decide that it's high or low and then call us because of that. So, and a lot of times it's not accurate. I told you already that we do not take blood pressures on dialysis patients, okay, on the arm where they have their fistula, where they actually access the veins and arteries to start the dialysis on them. And we also don't take blood pressures on the arm of a woman who had a mastectomy. So if she had a right-sided mastectomy, we wouldn't take it on the right side. And if she had a left side, we wouldn't take it on the left side. And if she had bilateral mastectomies, we cannot take blood pressures on her arms. And I wouldn't even bother. I would just take her to the hospital. I wouldn't try to get a blood pressure anyplace else. Okay, same thing like a dialysis patient. If they have fistulas on both arms, I wouldn't bother taking them on there. Okay. So there's no blood pressures on dialysis patients, no blood pressures on women who had mastectomies. Okay, temperature again, everybody knows what it is, right? We know that temperatures are elevated when somebody has an infection, and temperatures are elevated when somebody's exposed to high environmental heat. In other words, being outside in hot temperature and stuff like that. So, you know, and temperatures in kids typically are a little higher than temperatures in adults. The most accurate temperature is a rectal temperature, but obviously we don't do it in the field because it doesn't really, you know, lend itself to what we do. Probably oral would be the next most accurate way of doing it. Okay, and then, you know, all the ear and the forehead, those are, I wouldn't think to be as accurate as doing a true oral temperature. So, you know, when you have a patient who you think has an infection, oral is kind of the way to go. And then oxygen saturation, okay, is basically telling us how saturated the oxygen is to the hemoglobin. We use a device called a pulse oximeter. We are allowed to use it in New York State. EMTs are allowed to use it. Okay, it gives us an idea of their respiratory status. But if you had a totally normal pulse ox number and the patient told you they're having trouble breathing, I would still believe them and still give them oxygen. Okay, there's a lot of different devices, and there's also, just as important, there's a lot of different probes that go. So there's probes for fingers, there's probes for toes, there's probes for foreheads. On small kids, you know, a lot of times we go more towards the forehead because blood flow in kids to their hands are not great. It doesn't work on women if they have very heavy nail polish on. It doesn't work on people who do not have good blood flow to their fingers, right? So if somebody's shocky, it doesn't work. If somebody's in cardiac arrest, it's useless. It will not work because there's no blood flow. If somebody's cold, it doesn't work. So, you know, if somebody tells you to have Raynaud's syndrome where they, you know, their hands and feet are always cold, it doesn't work. So, you know, there definitely is some limitations. And like somebody said, you know, very intelligently before, it's useless in a carbon monoxide CO poisoning. Okay. So normal is 94 to 100%. Okay. Below 94%, we consider it to be mildly hypoxic. Okay. Below 90% becomes significant hypoxia. And, you know, when you get down into the 80s, it's severe. So I actually, the other night, had somebody that actually got into the 80s, and I have not seen somebody in the 80s in I don't know how long. So when they were having a seizure, their lips would turn blue and their pulse ox would drop down into the 80s because when you're seizing, you don't breathe well. But I never saw somebody, even during a seizure, get that hypoxic, you know, like that. So I was like, whoa, you know, that's pretty scary numbers and stuff. Again, it's not accurate in shock and hypothermia just because there's not good blood flow to wherever you put the probe. It's totally inaccurate in carbon monoxide poisoning because it's not telling you really what the problem is, right? Because the problem is a cellular hypoxia. Okay, there's other poisonings that we'll never be able to identify where it also, like hydrogen cyanide and stuff, we'll never even know. Excessive movement, more just because the probe will fall off, or if anything. Real dark nail polishes are a problem. And people who are anemic, which is more typically women, where they don't have a lot of red blood cells, you're going to get an abnormally low number, and they may not even be complaining of breathing problems, right? They'll just say, they'll call you because they feel weak, right? Because typically people are anemic or feel weak, and you know, you're checking them out and you put them on the pulse ox, and you say, oh my God, you know, your pulse ox is 80 or 90, and you know, it's not normal, and it's not anything really with their breathing. It's the problem that they don't have enough red blood cells to carry the oxygen. Okay, we can also measure blood glucose, right? EMTs are allowed to do that, so we will practice that in class. There's many different devices. They're called glucometers, okay, and we'll talk about it. Just remember, alcohol is a sugar, so if you wipe their fingers with alcohol, you're going to get an abnormally high reading. In saying that, people do it all the time, but what you should really do is dry off the finger with a gauze pad before you check the alcohol level. So I'm sorry, not the alcohol level, the sugar level and stuff like that. Okay, so we are allowed to use them. You just have to be trained in them. Those machines do have to be calibrated, or else they're not reliable, right? So that's somebody's job in the, you know, in your ambulance corps to calibrate those and stuff like that. Again, I'll show you how to do it. Okay, just you know, because we were talking about it, you know, what's a normal blood glucose level and somebody who's not a diabetic? Because remember, once they have the diagnosis of diabetes, you have to ask them what their normal level is, because every diabetic has a, you know, a normal range that they're trying to, you know, get at. They're not going to get the same ranges as somebody who's not a diabetic. So, you know, 60 to 80 is a normal range that our body usually is, right? But after we eat, it's going to go higher, okay, because of the extra sugar. But then once the body starts using that sugar, it should drop down to the 60 to 80 range in somebody who's not a diabetic, okay? Remember with kids, okay, their vital signs tend to be faster, pulse rate and respiratory rate, and their blood pressure tends to be lower because their heart doesn't have to push with that much force to circulate blood through their tiny little body. But their pulse rate and respiratory rate are faster because they need more of the fuels, right? They need more of the food of the body, the oxygen and the sugar and stuff like that. Okay, so I wrote here as far as reassessment that in a stable patient. What? Chulland? Chulland? Somebody said. Okay, so in a stable patient, we said that vital signs should be assessed every 15 minutes, okay? And that in an unstable patient every 5 minutes. So that's the test answer, okay? Remember, in real life, totally unstable patient, you probably will not have time every 5 minutes to do it because you're trying to keep them alive. Okay,
Can you repeat that one more time? I heard that Chulland. I got distracted.
I heard Chulland too, and it is Thursday. No, so on the test, they're going to say every 15 minutes on a stable patient and every 5 minutes on an unstable patient. And I'm saying to you in real life, okay, I have no problem every 15 minutes you check vital signs on a stable patient, you know, gives you something to do. But on an unstable patient, if you're trying to keep them alive, you may not have time to ever take one set of vital signs, never mind repeat it every 5 minutes, okay? So just realize that. And again, realize when you get to the hospital, they're gonna ask you for vital signs. And you just say, you know, I was too busy keeping them alive to, you know, get a set of vital signs, okay? Now, the last thing, number 3 says, vital signs should be assessed following all medical interventions, which means that this is really going towards drugs. So you don't know all the drugs yet that we can administer, and you don't know the effects and stuff like that, but there's certain medications that we give that can raise or lower blood pressures. Not that we're intentionally doing that, it's side effects. So we have to take vital signs after we give it. We actually have to take vital signs before we give it because there may be contraindications to giving it if the blood pressure is too low and stuff like that. Okay, let's do a quick review and we'll call it a night. Okay, so again, normal range for pulse we said is what? 60 to 80. 60 to 100, right? I mean, again, most people should be in the 60 to 80 range. Will tolerate 60 to 100. Respirations, you said 12 to 20. Blood pressure, okay, in adults, I mean, a book will say 110 over 80, okay? Doctor nowadays will look at 110 over 70. And children, I have to send it to you, but there's a chart of, you know, normal vital signs depending on age, and every age has a different one, so there's no way of remembering them all. Everybody typically has either an app on their phone or a little book they carry in their pocket that has all the different, you know, vital signs and also all the different home over-the-counter medications and prescription medicines, so you know what they're for. So there's a lot of different apps out there that you could, you know, if you have a smartphone, you could get, or they actually sell it as a little tiny book that fits into your pocket and stuff like that. Just remember that the ranges of numbers they're going to give you are not typical of the ranges of people who are having emergencies, right? They're always going to be off when they're having an emergency, either high or low. So just because we tell you what's normal, most people who have normal vital signs don't typically call the ambulance, okay? Trending, we said, is where we compare that baseline set of vitals or first vital signs, okay, to other ones, which we don't really usually get to do because we're not with a patient that long. So trending is the comparing of multiple sets of vital signs. Okay, we said 15 minutes for stable, 5 minutes for unstable on the test. Okay, again, consider if there's time to obtain vital signs. Okay, and the scene, you may want to try to get them en route, or you may not be able to get them at all. Okay, pulse oximetry. Okay, so, you know, we usually put pulse ox in the house. I mean, if they're not, you know, really emergent or anything like that, it takes 2 seconds to put it on. Can you put it on a patient with difficulty breathing? Yes. Can you put it in a patient without difficulty breathing? Yes. It's just another vital sign. There's no reason, you know, not to put it on someone, just real quick and stuff, just to rule out that there's any other problems. Okay. We said the vital signs, again, pulse, breathing, pulse respirations, blood pressure, pupils, skin color, temperature, moisture. Then they had pulse ox and glucose, right? So there's a lot of different things, but the 3 basic vital signs, again, are pulse, breathing, respirations, and blood pressure. Okay, why do we want to take vital signs more than once if time permits and the patient's condition permits, so that we see if there's any changes, right? How much time should you look for a pulse? If it's very hard to find, well, you know, you have to really get going, right? If you can't find a pulse in a patient, they're either, I mean, if they're talking to you, you know that it's probably your problem, not their problem. But if they're not talking to you, you have to decide if they're alive or dead and make a decision. Remember that if you're not sure if there's a pulse in an unconscious patient and you really can't be 100% certain, you should start CPR. And the worst that will happen is you will wake the patient up, right, if they just fainted with the pain of the compressions. So don't ever, don't ever fear starting CPR on someone if you're not sure whether or not they have a pulse.
Could you repeat again the vital signs?
It's in your book, but sure. So we said that for pulse, we want to look like 60 to 100, with 60 to 80 being, normal in an adult. Respirations 12 to 20, blood pressure 120 over 80. And in kids, there's too many numbers to remember them all. You need to use a chart. They're always going to be, again, pulse and respiration in kids is always going to be faster, and blood pressure is always going to be lower, okay?
What is the pulse ox numbers?
So a normal pulse ox should be 94% or higher. So 94% or higher, 94% going towards 100, okay? How should you react when a blood pressure monitor gives you a reading extremely different from previous readings? So you repeat it. In other words, if you've been getting, 110 over 80 the whole time you're with the patient and you get one abnormal blood pressure, then you just check it again. It's probably just an incorrect reading, or, the patient was moving their arm or something like that. Okay, how can you get an accurate pulse oximetry in a patient has, nail polish or fake nails or something like that? You may not. If it's just nail polish and they allow you to, we carry nail polish remover as they look like alcohol wipes, but it's nail polish remover, it's acetone. If they let you to, you can wipe off their nail polish. They usually don't let you because they paid money for it. If it's artificial nails, there's nothing you could do. Unless you have those other probes that go on the head, right? They can go on the temple or the forehead and stuff like that. So there's probably nothing you could do in those situations. And then I think the last thing is sometimes a patient's heart will have an electrical problem and beat more than 200 times a minute. That's true, right? So there are abnormal rhythms when the cardiac conduction system goes out of control. So it asks, why is the pulse tend to be weak when the heart is beating so fast? Anybody have any idea why the pulse would be weak when the heart, typically when the heart goes above 150, 160, the strength of the contractions tend to drop, right?
It's
You don't
compressing all the way.
What's that?
It's not compressing all the way.
Close.
If the veins dilate.
Well, veins, what do we care about? You mean veins?
Not the veins, the arteries, so they get
Nope.
they get bigger. No.
Doesn't have enough time to refill.
Excellent. Who said that? So what happens is when it's beating, okay, you guys are really impressing me. When it's beating 200 times a minute, right? The time between, remember, if it's beating 60 times a minute, you have a second in between each one. If it's beating 120 times a minute, you have a half a second, and so on, right? So if it does such a short time, it doesn't have time to fully fill with blood. It's actually as a term, it's called decreased, right? Decreased ventricular, the ventricles filling time. So when somebody's heart rate starts to increase that much, right, it doesn't have time to fill up. So it doesn't have anything to pump out. Now, the other consequence, if it can't pump out, what does it start doing? It starts to back up, right? If you can't pump blood out of your left ventricle into your aorta, it starts to back up into your left atrium, and then it starts to back up into your lungs. And if the pressure in your pulmonary capillary starts to increase, plasma actually flows over into the alveoli and the person feels like they're drowning. And that's called congestive heart failure or acute pulmonary edema. So that's sometimes when somebody's heart rate goes so fast, they actually flash over into what they call acute pulmonary edema and they feel like they can't breathe. There's other reasons why they can go into acute pulmonary edema, also called congestive heart failure, but that's one of them. So, and that's a real emergent problem. On a BLS level, there's really not much you could do. These would be situations where we would actually shock a patient who's conscious to try to stop their heart for a second and let it reset itself. Or we can sometimes try medications to give them to, reset their heart or to slow down their heart rate. So you guys had a very good, some very good answers to some hard questions. So I'm very impressed. I'm still trying desperately to finish your quiz. So I will continue to work on that, but I had a hellish week. I cannot wait for tomorrow night. And unless anybody has any questions,
I
I'm
have
done.
one question.
Yes.
Sometimes when you have an infant, a child, when they start
crying really hard and they can't breathe, they turn blue. What is that and why does that happen?
So part of it's psychological, okay? You could even have kids that could hold their breath so long that they pass out. It's just a phenomenon in kids. You know, I don't know exactly what causes, you know, a turning blue if they're breathing fast should not really happen, but I've seen kids that get so upset that they actually hold their breath. I've also seen kids that cry so hard that they breathe and suck in air and their belly gets distended and then it gets hard for them to breathe because they can't move their diaphragm. So, I mean, it's really more of a psychological thing, you know, because they're so upset and so, you know, stressed and stuff like that over something, that it's better just to kind of, you know, walk away from it and let them calm down and relax, and it usually, you know, goes back to normal. I mean, I've seen parents, I've gone to houses where parents have poured cold water on the kids, you know, because they're reacting, you know, crazy and stuff like that to kind of, you know, shock them into calming down and stuff. Usually, you know, when you talk to mental health workers, they say just, you know, walk away from it, you know, or somebody's saying blow in their mouth. I mean, you know, there's all what they call them, you know, mother's tales or wives' tales, like all these different, you know, home remedies and stuff. But, you know, most of the times people, you know, if you kind of walk away from their hysteria, they, you know, they kind of realize they don't have an audience and they kind of back down. But again, how do you know it's not an emergency, right? That's always the tough thing, right? How do you know it's really not an emergency? So, okay, what else? Anything else? Okay, so we will be back. I don't even know when we're back. I have to look at the schedule. Do we want to, is there skills Sunday? I do not know. Yankee, is there skills Sunday? He was on a second ago.
I think it is. I think it's going to be trauma assessment and I think it's going to be trauma assessment and maybe orthopedics. It's splinting.
Okay, so just ask David to send out a text to everybody because you're going to want to schedule people. Do we want to have a review session Motzei Shabbos, or we want to take this week off? Yeah. Okay, I will try to remember tomorrow to set out a Zoom invitation. And I guess we're doing it 9 o'clock again? Yes? Okay. Okay, so everybody have a good rest of the night, a good Shabbos, and I guess some of you I'll see Saturday night, okay?
All righty, thank
you. Take care.
Good night.
Good night.
Good night.
Good night.